Good afternoon, everyone. So today I'm going to present on the topic unraveling the enigma of ocular sarcoidosis. So in the first case, a 45-year-old female presented to us with the chief complaint of floaters in the right eye since 1 year. Her vision in both the eyes was 6/9 with the pinhole and not improving further. Both the eye shows cells. In the right eye, they were more as compared to the left eye. Both the eye shows vitritis, vitreous membranes, snowball, and candle wax drippings, and they were more in the right eye as compared to the left eye. This is the OCT image of both the eyes. Skin lesion just below lower eyelid noted. Investigations were done, and she is a known case of pulmonary sarcoidosis. Mantoux came out to be negative. Serum A's were on the higher levels. ESR raised, and the rest tests for uveitis were within normal limit. FNAC from skin lesion confirmed cutaneous sarcoidosis. So the diagnosis of definite ocular sarcoidosis was made. Treatment, she is on oral and the topical steroids. Over a period of 8 months, her skin lesion healed and the pulmonary symptoms also improved, but still she has recurrent vitritis. In the second case, a 30-year-old male presented to us with the chief complaint of floaters in both the eyes. His vision in both the eyes was 6/6 with the pinhole. Both the eyes showed vit cells +2, but in the left eye, there were old KPs also present. Diagnosed elsewhere as viral parotitis, showing parotid gland enlargement. At presentation, both the eyes showed disc edema as well as candle wax strippings in the periphery. Investigations were done. Serum A's were on the higher level. Mantoux showed no induration even after 72 hours. Chest CT showed significant findings. Diagnosis of the Heford-Weldon syndrome was made, so we thought it is presumed ocular sarcoidosis. Treatment, oral and the topical steroids. Over a period of 4 months, the posterior uveitis completely resolved along with the resolution of parotitis as clearly indicated in these pictures. In the third case, a 40-year-old male presented with gradual painless diminution of vision in the left eye for past 2 weeks. His vision in the right eye was 6/6, left eye 6/12 part. On the posterior segment, right eye showed subtle subretinal yellowish lesion along the IT arcade and the nasally, whereas in the left eye it was along the posterior pole along with the SRF. These are the FFA and the ICGA finding of the corresponding patient. On the B scan, thickening at the posterior pole with the high surface reflectivity and internal variable to hypoechoic signal was present. So following DDs were made. Investigation was done. Everything was normal except serum A's were on the borderline only and the Mantoux showed no induration. Chest CT shows few sub-centimeter sized mediastinal lymph nodes. Diagnosis of query-sarcoid granuloma in a case of presumed ocular sarcoidosis was present. Treatment on the oral steroids. 4 weeks after treatment, there was complete resolution. In the fourth case, a 35-year-old male presented with blurring of vision in the left eye since 25 days. His vision in the right eye was 6/12 with pinhole and the left eye 6/24, which was not improving further. Right eye fundus completely within normal limit. Left eye shows large optic disc granuloma, basically reaching up to the optic disc and posterior pole. OCT of the left eye. FFA clearly shows late phase disc staining and the large hypofluorescent area which can be seen reaching up to the optic disc and at the posterior pole. Investigation were done. Serum A's were significantly elevated. IGRA came out to be negative. CT scan showed the significant finding. Appearance are suggestive of pulmonary sarcoidosis stage 3. Diagnosis of presumed ocular sarcoidosis was made. Treatment, oral steroids. 30 days after treatment, these show the resolution. So now comes to the discussion. Sarcoidosis is basically a systemic inflammatory disease of unknown etiology characterized by the formation of known casseting granulomas. These are basically the findings which can be seen starting from the eyelids and can reach up to optic nerve and visual pathways also. Following pictures, A shows the mutton fat KPs, B multifocal choroiditis, C perivenous shinding along with the hemorrhages, D large granuloma along IT arcade, E shows the chorioretinal lesions. This is also few of the pictures. B shows the hot disc, C few hypocyanous spots in the ICG. This is the sarcoidosis of the skin. We have the similar picture in our case. Broad raised skin lesions or plaques that can be smooth or rough and skin red or brown. These can also be seen arising from tattoos. This is the original article basically distinguishing TB granuloma from the sarcoid granuloma. Top row shows the sarcoid granuloma which are usually intense yellow, have the SRF and bigger one, whereas the bottom row shows the sarcoid granuloma which are usually small, dull yellow, rarely distinguished from the retina. This distinguish between the OCT of the TB granuloma and the sarcoid granuloma. Basically in TB granuloma there is a contact sign, RPE disruption and the outer retinal layer reflectivity is present. Whereas in the sarcoid granuloma these are usually small and there is no outer retinal hyperreflectivity and usually the RPE is intact. Evaluation can be done from the international workshop criteria. Treatment, basically corticosteroid is the mainstay. Rest, these biological agents can be given. So the conclusion is it is important for the ophthalmologist to be aware of ocular manifestation of sarcoidosis, as they may be the first sign of disease and can lead to severe complications. Thank you.
Any questions from the judges, sir?
Pariksha, there are all clear-cut patients, most of them,
Yes,
and all
sir.
responded to steroids. So what is so unusual about this?
Sir,
Yeah.
usually it means that the oral steroids, usually patients resolve. In
That
very
we
few
know,
patients,
that we-
antimetabolites are started.
That we know for times immemorial now.
Yes, sir.
Yeah. Even when we were residents, that was the clear serum ACE levels, lymph nodes, and typical presentations. You presented 4 patients.
Yes, sir.
Presentations are pretty good from documentation point of view.
Okay, sir.
But it's okay that no. But only thing is there is nothing that we become wiser after listening to these 4 cases. They're all very typical patients. First was very typical known patient of pulmonary sarcoid. Second was presumed sarcoid. The third, fourth was a granuloma. Granuloma point I think was interesting because that can sometimes mimic a lot of other things.
Yes.
So I think you should also highlight how you showed one slide where mimic the between tuberculosis as well as sarcoid.
Yes, sir.
So
There-
people get sometimes confused or taken aback. The reason is why I'm saying so because whether to start ATT or not in such patients, that somehow you should highlight also.
Yes, sir.
Apart from investigations of serum ACE levels and MON2 test, nowadays we have to rely on HRCT for tuberculosis also.
Yes, sir. It was done in almost every patient. Chastity was done.
So very good.
Thank you, sir.
Thank you, Dr. Pariksha. Is Dr. Anusua Kapoor here? Okay. Can we go on to the next doctor, Dr. Prasanna V. Ramesh? Please come forward. Requesting the next presenters to be ready, Dr. Subhangi Sahu and Dr. Afsana.
Thank you for the opportunity. So I'm going to talk on FACO KDB versus FACO BANG. So MIGS is one that is up and coming, and this study is about comparing the early outcomes of 2 such excisional goniotomy devices. One is KDB, which is made for this particular purpose, and other one is the bent ab internoneedle goniectomy, which is called the BANG with 25 and 27 gauge needle. So the purpose of it is to include mild and moderate POAGs who are currently under AGMs, and the primary outcomes were reduction in number of intraocular pressure from baseline pre-op versus post-op, number of anti-glaucoma medications, how many had greater than 1 AGM bottle reduction with medication-free population, with complete and qualified success as secondary outcomes. And the World Glaucoma Guidelines of complete success, qualified success, and failure was actually followed. And the methodology was a prospective comparative study done with all consenting consecutive patients during the 6-month period, with 71 patients being included in the study for a follow-up of another 6 months. And they were graded based on the Humphreys or the Octopus Visual Field as mild or moderate POAGs. And based on the logistics, especially economics involved, 32 patients choose KDB and 39 went into the BANG procedure for a combined phacoemulsification with cataract. And this is an open label study with both the patients and researcher being aware. And along with gonioscopy and anterion was also done at 6 months follow-up to see the post-angle dynamics of this particular study. So this is a short depiction of the Kahook dual blade procedure where the KDB blade was actually used to excise the goniotomy, as you can see here. And if there was a remnant trabecular meshwork that is hanging, an ILM peeling forceps was used to release it. And this was the bent ab interno needle goniectomy procedure where the 26 gauge needle was used to perform the same, but it was not made for it. So the pair t-test was used to evaluate, and this is the FACO KDB group. IOP from 22, it came down to 16, you can see here, and this is the reduction in number of AGM from 1.16 to 0.62, along with greater than 1 AGM and medication-free population, with a complete success rate of 72%. And in the BANG, you can see from 20 to 15, more or less the same. And the AGM reduction was also from 1 to 0.49, 1.07, with medication-free population only being 50% at 6 months, and the complete success being 48. So let's see a quick comparison here. The path chosen is different, but they have a common destination in reducing the intraocular pressure. Similarly, in terms of IOP as well, where KDB had a slight edge, and the reduction in number of AGM also was quite similar. But here, if you see the greater than one bottle reduction and the number of percentage of bottles or medication-free population, they seem to be slightly better in the KDB group, and these are the demographics of the study. And complication profile, there were few microemphysema in the KDB group, whereas with BANG, there were few patients who had some choroidal folds with no hypotony, and there was one patient having an emphysema which was quite lasting 1 week, and 2 patients developed peripheral anterior synechiae. So these are some of the post-op images of the BANG. And then the anterior images gave a clear-cut picture of a W sign, whereas in BANG you can see there was some remnant of trabecular meshwork leaflet that was there. So both the procedures reduced effectively the IOP. In patients whom KDB was performed, the IOP was comparable to the BANG, while the decrease in the number of AGM was also comparable. But post-operatively, the medication-free patients were higher in the KDB group, and KDB group achieved a complete success of 72% and maintains a total success of 87, whereas BANG was able to maintain only 48 and 74, and the failure rate was double that of the KDB group. That is because of the remnant leaflet theory. Have a look at this particular theory, which is what presumably could have happened. A KDB blade is actually quite smooth, and just like scooping an vanilla ice cream, it completely scoops the trabecular meshwork with a clear W sign, whereas with BANG, we tend to have few leaflet remnants because it doesn't have the dual blade and the ramp to really scoop it off. So there are few remnants of trabecular meshwork which can serve as a precursor for PAS. Literature in KDB is there, whereas BANG is quite new, and that also supports this study. And there is few adjacent trauma that can happen with the BANG, which is very minimal with KDB, where there is a surrounding tissue injury. That is why you can see a clear W sign in a KDB, and these are some of the pictures of the same. So to conclude, my dear friends, phaco KDB versus phaco BANG, though both are excisional, provided a comparable IOP and AGM reduction, but the failure rate with this bent ab interno needle goniectomy, the frugal needle that we are using, seem to cause some additive surrounding injury, where it can go in for a failure quite early compared to the BANG, and the proportion of the eyes able to reduce 1 or more AGM while maintaining the IOP less than or equal to 21 appear to be eyes in the eyes undergoing KDB slightly superior to BANG. So there are some limitations. We need to have more RCTs, and these are the future directions. Thank you for the opportunity once again, for giving me this opportunity.
Most of the people may not know it.
Yes,
Just shown at least one picture, although your study is very well done and
Yes, sir.
conducted. Of course, it's a open sort of, you didn't do anything where we could...
Sir, MIGS is something that is very upcoming, sir. We have the stenting devices as well and the excision devices. So there was a video where KDB is having a Kahoot dual blade which lifts the trabecular meshwork and then scoops it off. Whereas with the bent ab interno needle goniectomy, a frugal innovation, the Rexis needle that we use, we bend it the other way around, and then we try to do the same. It's a frugal version of KDB. So, but KDB seems to be superior in terms of tissue injury as well as tissue recovery, which is very important for angle surgery especially. At early outcomes are coming that both are equivalent, or it looks like it's equal in terms of IOP and AGM. But the catch here is the ability to reduce the intraocular pressure. The number of failure rates are slightly higher with BANG, and it's very upcoming, sir. With more data, more follow-up and multicentric trials, we'll be able to, yes, sir. Thank you, sir.
Excuse me,
It was a 4-1.
Pardon me, sir.
It was a foregone conclusion only because of the adequate removal of trabecular meshwork in KDB and just a goniectomy in BANG. So all the things were, I think, right from the word go, once you show the video, we were hoping that KDB would definitely do better. It was a foregone conclusion for me at least.
Sir, in glaucoma armamentarium, sir, ASOCT is there and UBM is there. So this novelty here again is anterion, sir, because anterion was never used to visualize the post angle in a MIGS surgery. So
No, my question is that because KDB ensures complete excision,
yes, sir.
obviously success rate will be more and failure rate will be less.
So, but
No.
BANG has also been highlighted in the
Yeah,
market
I know.
as it's a similar
no, but
to
tell me what the instruments that you use for the BANG is a needle, which is also a type of needle that you can make yourself, or
yes, sir.
or
BANG,
it's an ordinary 26 gauge needle which you can make yourself.
it's a
Whereas the KDP one is a special device, isn't it?
yes, sir.
Which is a very costly device.
So cost wise depends, sir.
Which is a very costly device because I mean And the success, if the bank success is much better than the KDP and the cost is much more, what do you think will be the future of this?
So there is, in excision at least, if you are taking MIGS and excisional goniotomy, KDB seems to be superior to bank. But if you're looking at cost effectiveness, there is another one that is coming into the armamentarium called as suture GAT. Suture gonioscopy assisted transluminal trabeculectomy, where you use only a 5-0 suture, where you open up the canal from inside. So for cost, logistics and other thing, the stenting was sounding more, so we went into this bank. Now we are moving into sutures where the suture is being threaded and that is being opening the canal from inside out. So these are some cost alternative options, sir. KDB is costly, but it is not as costly as a stenting device. Yes, sir.
So, but the intraocular pressure reduction in all these cases, is, how many, what, with all these procedures about 5 to 6 millimeters or more than that?
Sir, these are all mild to moderate POAG patients. I have not used severe POAGs. I have not used angle closure POAGs. So if you are going to enhance the spectrum into angle closures where we do goniosynocular followed by an angle surgery, as well as if you go for severe POAGs, then you may have a much drop in intraocular pressure as well. Because
These are all open angle cases.
all open angle and all mild to moderate cases only, sir. Yeah. Thank you.
Thank you, Dr. Prasanna. Is Dr. Shubhangi Sahu here? Please come forward. And Dr. Afsana, please be ready on the next podium with your presentation. Dr. Afsana, are you present? Yes. Dr. Pratik Nishant? Okay. Dr. Zainab? Dr. Zainab Nahid? Okay. And Dr. Anusuya? Okay, ma'am.
Good morning, everyone. Today I shall be presenting the clinico-demographic and etiological profiles in acquired esotropia. I have no financial interest to disclose. The primary objective is to study the clinico-demographic profile in patients with acquired esotropia and to report the varied etiologies. It is also to determine the functional outcomes in these subset of patients. Acquired esotropia can be acute or chronic in onset with variable progression. The prevalence is around 10.4% of the total diagnosed esotropia cases. Acute esotropia can be comitant or incomitant. In the comitant variety, acute acquired comitant esotropia is characterized by an acute onset of esotropia with an equal angle of deviation in all fields of cases. As per Burien-Miller classification, there are 7 types of acute acquired comitant esotropia. In the incomitant variety, it is an esotropia with varied angles of deviations in different cases. Acute esotropia may present as have variable etiologies like ischemia, trauma, etc. The study was a prospective study conducted in the Department of Ophthalmology in KIMS Bhubaneswar with a sample size of 21. Detailed ocular and systemic evaluation of all the patients was done with ocular and laboratory investigations wherever applicable. The inclusion criteria took diagnosed cases of acquired esotropia with an age range of 5 to 55 years and excluded severely ill patients or patients admitted in ICU. It also excluded infantile esotropia patients and patients with history of previous ocular surgeries. These patients were followed up for first, second, third, and 6 months. The statistical analysis done gave us a p-value less than 0.05%, which was considered as statistically significant. On demographic parameters, the mean age was 32.3 plus minus 0.36 years, and there was a male preponderance in our study participants. The most common presentation was bilateral. On best corrected visual acuity in logMAR units, we found that there was a significant improvement in vision starting from presentation to 3 and 6 months of follow. Coming to etiology, neoplastic etiology was the most common, followed by post-fever and ischemic etiologies. On laboratory evaluation, deranged serum homocysteine lipid profile, ESR and HbA1c was noted in ischemia, whereas in idiopathic intracranial hypertension, there was decrease in serum iron and ferritin levels. On OCT, there were 43 patients had RNFL thinning, whereas 36% of the patients had RNFL edema and thickening. On CSF analysis, 20% of the patients had viral meningitis, and 26% of the cases had CSF suggestive of malignancy. The neuroimaging was also performed. MRI brain and orbit with contrast, along with MR venogram with contrast was done wherever needed. And the raised intracranial pressure was the most common finding, followed by hyperintensity and enhanced lesions in meningioma. We also performed HFA in 24-2, where advanced field loss was the most common finding, followed by enlarged blind spot and inferior quadrantopia. So in some patients, due to poor vision, the fields could not be obtained, which was 26% of the patients. Coming to discussion, in the study done by Clark and Nelson et al., acquired esotropia was found to be secondary to refractive errors, decompensated esophoria, and prolonged near work. In the study by Buick-Winding et al., it attributed to elevated intracranial pressure, tumors like glioma or Arnold-Chiari malformation. Cerebral and thalamic tumors were also a major etiology. In the study by Liu et al., in 30 children presenting with acquired esotropia, 12 had comitant esotropia, whereas the rest 18 had concomitant esotropia. In our current present study, neoplastic origin was the most common, followed by infective and ischemic etiologies. So the take clinic message from my presentation is that majority of the patients presenting with acquired esotropia have neoplasia as a major underlying cause. Patients with refractive accommodative esotropia are orthophoric at final follow-up after using glasses with good compliance. A detailed history, thorough clinical radiological evaluation, along with adequate lab investigations will help us in clinching the appropriate diagnosis at final follow-up. These are my references. Thank you.
Required complete workup,
Yes.
and especially the neurological, and that's what you mentioned, which is very well known for a long time, because that is something we can't ignore at all. So what really you wanted to convey, which could give us little additional information in your study?
Sir, our study combined all kinds of etiologies so that understanding the underlying cause, we can provide a better inventation on a quicker time as compared to delayed presentation. So that if we understand the underlying etiology, it will lead to a better patient care.
Shubhangi, excellent contribution, at least from refractory error to ICT to neoplasia, you have said. I would have appreciated in a competitive session like this should show pictures also. You see, none of the picture I could see, neither OCT, RNFL thinning, and HFA or some neoplasia evidence. You see, whenever you present, you should show यहाँ पे neoplasia था, RNFL thinning ऐसा था. So that will add value to your. Plus, do you think that once we're talking of clinico-demographical and etiological profiles, 21 patients are good enough?
No, sir, the scope
This
could be
too,
widened further.
Because 21 patients and drawing such a big conclusion, थोड़ा सा sample size बड़ा होना चाहिए.
Yes, sir. Thank you, sir.
Thank you, Dr. Shubhangi. Dr. Afsana,
Yes, ma'am.
please start.
Good afternoon, everyone. Today I am going to present an interesting topic of non-seeing child sensitization to MELAS in an emergency ophthalmology setup. I do not have any financial disclosure. Just before going to my actual case, I would like to briefly introduce about the topic, that is MELAS. MELAS is mitochondrial encephalomyopathy, lactic acidosis and stroke-like episodes. It is frequently inherited mitochondrial maternal disorder which affects the tissues which has very high metabolic activity like skeletal muscles, heart, brain, kidney, eye. So it affects the various organs with variable presentation. The most common mutation is MTTL1 gene. So what happened with this mutation? This mutation will lead to decreased energy production at the mitochondrial level. That will lead to increased anaerobic glycolysis and will lead to increased lactic acid. And that increased lactic acid, depending upon the site of the tissue where it is collected, it will lead to signs and symptoms in the patient. Now coming towards our case, a 1-year-old male child presented to pediatric emergency with the abnormal body movement and fever since 2 weeks. After the stabilization of the primary complaint, the child was referred to ophthalmology department in view of poor eye contact. The child presented to us with this complaint, already undergoing treatment for the same. The development history for the child was normal before the onset of symptoms. There was normal birth history and the immunization history. Upon systemic findings, we found that the child has focal onset seizures which involve the left side of the upper limb and the lower limb. Upon central nervous system examination, we found in the motor examination the tone was variable on the left side, power was more than 3/5, reflexes were very brisk on the left hand side, suggestive of upper motor neuron lesion, and plantar reflex was also bilateral downgoing. Rest all their cardiovascular, respiratory and per abdomen examination was within normal limit. Now moving toward the investigation, we did CSF tab that was found to be acellular. In venous blood gas analysis, lactate was found to be raised, suggestive of lactic acidosis. In the MRI brain, we found the hyperintense lesions on T2 and flare with restricted diffusion, suggestive of encephalitis more than infarct. Upon ophthalmologic evaluation, we found that the child was not fixing to light, pupils were normal, extraocular movements were full, anterior segment examination was within normal limit. But when we did the posterior segment examination, we found hypopigmented lesions over the posterior pore that corroborated with the reported ophthalmologic findings in MELAS, which are observed in approximately 40 to 50% of the cases. So with the triad of presentation of encephalitis, stroke-like episodes, and lactic acidosis, along with our ophthalmic findings of pigmented retinopathy, help in diagnosis of MELAS that was later confirmed with a genetic testing, which was found to be positive for MTTL1 gene. So which was also seen from a review article of pediatric neonatology that the ophthalmic manifestations are the second most common manifestations in these mitochondrial disorders, and these has various presentations like ptosis, RP, external ophthalmoplegia, visual loss, etc. So a non-seeing children can be a diagnostic puzzle for pediatric ophthalmologists, but if we are aware about these findings, it will help the pediatric ophthalmologist and neurologist in clinching the diagnosis and starting appropriate management. So my take-home message from my case is early ophthalmic evaluation is a valuable diagnostic tool in the multidisciplinary approach to MELAS management, and ophthalmic findings should not be overlooked. As MELAS has no cure, the child has to die, but our patient died at 1.2 years of age. So if we early diagnose the patient, we can prolong the life of a patient, because the reported literature shows that this child usually dies at the age of 35 years of age. Thank you.
I think this was nice presentation, but in the title you have written MELAS. Many of the people may not know what is MELAS.
Therefore,
So you have to justify each of the very abbreviation, and may not be placed in the title, ideally.
Yes, sir.
What is MELAS?
Sir, MELAS is mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes. It is a mitochondrial disorder, basically hampered the energy production at various parts of the tissues.
Now, how did you think about going into this aspect of this study, in this study? Just because you saw the child was blind, or how did you think about this?
Sir, actually we got a referral from pediatric department to look for visual acuity of the child. Then we did further follow-up and found in the literature and confirmed.
By pediatricians.
Sir, after
You just find the ophthalmic evaluation, that's all.
After reporting of our ophthalmic finding, they sent genetic testing for MELAS, which was found to be positive.
But how should we suspect MELAS?
No, did we suspect MELAS, or did they?
They are suspecting mitochondrial disorder, sir.
And then you investigated it.
We investigated.
No, they only investigated.
They.
They investigated.
That what was your role in this?
Hypopigmented patches.
I think it will be very difficult for pediatric ophthalmologists or anybody to primarily diagnose this condition, because this requires
Yes, sir.
pediatric neonatologist this thing, as well as, of course, they require genetic testing. That is what is very important these days. Otherwise, they won't establish the diagnosis.
No, my this thing was how, as an ophthalmologist, I should suspect MELAS in a child. It's not possible. Na?
No, sir.
So that's what we were looking for. You
It's
see,
just-
as a pediatrician, तो पूरी नेल्सन की किताब हमें आनी चाहिए, वो तो that's impossible. What I'm saying is, this study would have become wiser in case, our role should also increase. And एक बच्चा देखा, he can't fix it. Should I suspect MELAS? No. So when should I suspect MELAS? Chal, good.
Thank you, Dr. Afsana. Dr. Pratik Nishant. And I request Dr. Zainab Nahid to be on
Good morning,
stage.
esteemed chair, ladies and gentlemen. Correlation of MIBO scale, symptom score, and sign score for primary meibomian gland dysfunction in India's eyes, a cross-section study, no financial disclosures. So meibomian gland disease, or MGD, is characterized by terminal duct obstruction and changes in the glandular secretion. It is the most common association of dry eye disease, and there are certain risk factors known for MGD. There are several grading scales available for MGD, but they are very cumbersome. There is significant inter-observer variability leading to greater variation, and OSDI evaluation ocular surface disease index, the 6 MGD sign scores, and the improved MEBO scales are means of assessment, but there is non-availability of a validated MGD scale suited for the Indian outpatient setting, which is a gap in the present knowledge. So although the three systems can help in grading, there is no evidence that there is a correlation between them, and evaluation of the correlation will help us analyze whether the improved MEBO scale used alone can determine the severity of MGD or a combination of the grading systems is needed. To the best of the author's knowledge, such a study to correlate meibomian gland loss scores as per the improved MEBO scale has not been conducted. So this was a hospital-based cross-sectional study from October 2019 to 2020 in Uttarakhand, approved by the Institutional Ethics Committee in patients with primary meibomian gland disease. All participants filled the OSDI form, completed the ocular examination by expert ophthalmologist, and eyelid margin examination was done during the slit lamp, by which the MGD sign score was calculated. Infrared imaging of the upper and lower eyelids was done using a specular microscope, and the areas were visually assessed and compared to the photographic card, which is the improved MEBO scale photographic card. So OSDI was calculated as per protocol. MGD sign score was calculated as per the sum of the 6 grading systems, which is mentioned here. And the MGL score was basically a visual comparison between the standard photographs as described by PULT. So on the right, you have the MGD MEBO scale, the MGD meibomian gland loss assessment. On the left, this is how it appears on the specular microscope. In the center, you have the slit lamp photographs. A sample of 124 eyelids was calculated to be compared, and appropriate statistical tests were used. The PMS correlation coefficient was used, and greater than 0.5 was considered clinically significant. The Jong-Heat-Upstrut JT test was applied to evaluate the distribution of varying ordinal scores, and the R effect was used to calculate the effect size. So 68 Indian subjects and 212 eyelids were assessed. There were 29 males and 24 females, and the mean age was 57 years. This is the scatter diagram showing the comparison of OSDI MGD sign score and OSDI and the meibomian gland loss, or the MGL score. These were not clinically significant. However, the comparison of MGL score with MGD sign score showed strong correlation, which was statistically significant, and the correlation coefficient of 0.83 was clinically significant. So the JT test applied to the MGD sign score was statistically significant and found a large JT statistic with a large effect size of 0.93. So the study evaluated validated symptom score, validated sign score, and the improved MEBO scale, and the clinical utility of photographically aided scales such as the MEBO scale is poorly studied in literature. The existing basis, which is the study by Arita et al., utilizes both biomicroscopy and meibography for the interpretation, which is cumbersome. The visual scale, the MEBO scale, comprises of just a picture card, which allows the observer to assign a score based on the patient's observation of the meibomian gland morphology. Linear regression analysis correlates it well with OSDI. However, this is not possible in the clinical setting. The sum of both eyelids has been studied. The scores of both eyelids has been studied by Wang et al., but this was correlated with the speed questionnaire. The percentage total area as calculated by computer software is also possible. However, this is costly and not available widely. Robin et al. Have compared the meibomian gland loss compared to the OSDI, but they did not correlate the two parameters as to what is the correlation. Brooks and Gupta have shown the initial presenting MEBO scale score in patients of refractive surgery, but they have not provided details about those with pre-existing MGD. As per our findings, the MEBO scale alone can be used for reliable assessment and grading of the MGD. Given the large sample size, the results are externally generalizable. However, we still recommend independent symptom assessment through OSDI. There are certain limitations of the study as to the inability to examine the association between the parameters considered and other factors, the effect of recall bias, and there is scope for further studies as well. However, to conclude, in Indian subjects in the outpatient setting, MEBO scale alone can be used for reliable assessment and grading of primary MGD, as the score so obtained has clinical utility similar to the sum of 6 sign scores. We still recommend independent symptom assessment through OSDI or a similar questionnaire for dry eye in all patients, as the MEBO scale has poor clinical utility in predicting the symptoms. Thank you.
Was your what? What was the, why did you do this study? What is the usefulness of the study?
So, sir, the clinical assessment of meibomian gland disease is quite variable as per the inter-observer variability that is there. There is no standard that is used across institutions, across.
How did you standardize this?
So the standardization is basically on the visual assessment of the direct observation of the meibomian glands on specular microscope or any other comparable
That is the only
camera.
test you had, was this thing.
Pardon, sir?
Did you say study the lipid layer, the aqueous layer, the other layers of the tear film, or we just based it on these
Just
photographs?
based on the meibomian gland only, sir. The other parameters were well correlated with this. As per the study by Arita et al., the existing science scores, which are too many science scores that are currently used, all of them are well correlated with just the observation that we have made on the photographic card.
So what would you suggest should be the way forward for people to assess dry eye? For instance, if I have a machine, what should I assess as a very conclusive evidence of dry eye?
For meibomian gland disease, only the meibomian gland disease part of it, sir, I would recommend that currently the slit lamp examination be extended, and an instrument that is available in the OPD, like an autorefractor or specular microscope, be used to visualize the meibomian gland morphology directly under infrared imaging, and the morphology that is observed be compared to the MIBO-scale card that is freely available on the internet, and only that is sufficient. It is well correlated with everything that is being currently used to grade MGD.
Okay, thank you. Because today the MGD or the dry eye has become a sort of a fashionable entity now, in the sense that people, the amount of investment in MGD machines is, so if there's something so basic can come to a conclusion that you can treat patients on this basis, then it will be really worthwhile, because people are spending thousands and lakhs of rupees on these machines to come to a conclusion whether a patient has dry eye or not.
Actually, sir, we were also surprised to see the correlation coefficient of 0.83. We were very particular on establishing what is the weak correlation, what is the moderate correlation, and what is the strong correlation. We went back to the scientific and statistical literature to find out whether such a limit has been defined. And anything above 0.8 is strongly correlated and is clinically significant. So this study actually has the potential to change the practice, because the large sample size and the clinically significant correlation coefficient are sufficient to, for a person to extend the study further and rather propose a guideline according to this.
Thank you.
Thank you so much, sir. Thank you.
Thank you, Dr. Pratik. We can go ahead with the next presentation, Dr. Zainab Nahid, and it will be followed by the last paper of the session, Dr. Anusuya. Ma'am, please start.
Good afternoon, respected judges and delegates. I am Dr. Zainab Nahid, and I'm going to present my study on variations in the central corneal thickness during the menstrual cycle in Indian women. The study was done under guidance of Professor Deepak Mishra sir. I have no financial disclosure. Introduction. The menstrual cycle in women has fluctuating hormone levels. LH receptors are found in ocular tissues such as the cornea, iris, ciliary body, lens, conjunctiva, lacrimal and meibomian glands. These hormones can increase the central corneal thickness by water retention in the corneal stroma. It can also increase the intraocular pressure during the menstrual phase, and it can also influence the tear film production and stability. So the aim of this study was to determine the variations in central corneal thickness during menstrual cycle in Indian women. Materials and methods. This study was prospective observational clinical study done in RIO and Obstetrics and Gynecology Department of IMS BHU. Number of subjects were 126, which were followed up for 3 years, and it was ethically approved. The inclusion criteria was women between 18 and 45 years of age with normal menstrual cycle. And exclusion criteria, we had previous history of eye surgeries, conditions affecting the central corneal thickness like keratoconus, scarred corneas or dry eye, history of infertility, polycystic ovarian disease, pelvic inflammatory disease, contraceptive use, breastfeeding and diabetes mellitus. We screened 735 females, out of which 163 females fulfilled the above criteria, but 37 females refused to participate, so study was done on 126 females. Self-reported dates of the menstrual cycle by the participants were noted. Ovulation time was confirmed by the urine LH level, luteinizing hormone levels of 25-30 international unit per liter was taken to confirm the ovulation within 24 hours. A complete ocular examination was done to rule out any ocular abnormality. CCT was measured by an ultrasound pachymeter, Tome SP 300 pachymeter within consecutive 3 days in all 3 phases. Data were analyzed by SPSS version 20. So now on the results, we got the mean age of participants was 26.6 plus minus 2.6 years. The mean duration of cycle was 27.9 plus minus 2.9 days. In 92% of women, CCT changes were seen, while in 8% there was no difference between any phases of the cycle. So what we got, the mean central corneal thickness of both eyes were 541.76 plus minus 4.21 micrometer at the start, 559.21 plus minus 4.50 micron in the middle, 544.52 plus minus 8.06 micrometer in the end of the cycle. So we compared the mean central corneal thickness of the right and left eye in micrometer during the different phases and the entire menstrual cycle, and we applied the t-test, unpaired t-test in the beginning, middle, end, and entire cycle, and what we got that it was not statistically significant. But when we compared the mean central corneal thickness of the right and left eye during the different phases in the left, right, and overall, like between the beginning and middle and end and the beginning, what we got that the values were statistically significant. So in discussion, I would like to say, and there was a study by the Feldman et al. And Sony, and they stated that lowest central corneal thickness just before ovulation and maximum at the beginning of the cycle. Kylie et al., the cornea was thickest at the time of ovulation, and study done by Faruqi et al. Concluded that the cornea was thickest during ovulation time and the thinnest at the end of the cycle. In our study, the cornea was thickest at mid-cycle, followed by the end and beginning of the cycle. So we concluded that CCT value was significantly higher during ovulation compared to the beginning and end of the menstrual cycle. So our study recommends that menstrual history may be included in the workup of females undergoing refractive surgery, intraocular pressure measurement, contact lens fitting trial. There are some limitations of the study also. The stages of the menstrual cycle and follicular maturation were not verified by abdominal ultrasound. Luteinizing hormone levels during all phases of the menstrual cycle were not measured, so correlation between central corneal thickness and luteinizing hormone levels was not possible. We could not explain which layer of cornea is responsible for changes in CCT as we used ultrasound pachymetry. These are my references. Thank you.
What do you think will be the real utility of, real utility of this kind of a study which you have done? Because you'll take the menstrual history during the, as you said, during the workup for various refractive procedure. Will it make much difference? Because it is such a minimal difference in thickening. Will it make a difference? Is it significant?
Actually, we never asked the menstrual history of when we do refractive surgery on the patients. And also in glaucoma, the menstruation is a monthly phenomenon. So how would you benefit from such a study in the sense in terms of glaucoma or even in terms of refractive surgery? How would you really benefit from this study? Because what would be the usefulness of a study like this?
So actually in most of the post-operative refractive surgery, sometimes we get refractive surprises in patients. So this study, because in our study we concluded that during ovulation there is significant changes in the central corneal thickness. So it can, and this study was never done in the Indian population. In UK it was done and it was published in PubMed, but there is no study which was published in on PubMed in Indian population. So we did this study so to avoid any post-operative refractive surprise in females. Just like in glaucoma also, like there is change in central corneal thickness because in change in IOP. So because it is hypothesized that during ovulation period, there is a secretion of the antidiuretic hormone, surge in secretion of antidiuretic hormone, which increases the intraocular pressure, and in response to it, there is increase in central corneal thickness.
Zainab, the question is that 18 micron difference we have shown between beginning, mid, and mid mein sabse zyada hai. That is around 559. 18 micron. And is it significant enough? Because we know that all these menstrual hormones cause water retention.
Yes.
Cause water retention, and thickness is bound to have. I do not know whether it's a visual impact or not. Because even with glasses, suppose somebody is wearing glasses, तो blurring of vision तो उससे भी होगा ना, अगर होना है तो. Only thing is thickness 18 micron for few days it will be there. Is that right? 18 micron. This is what I have
What
understood.
would be the clinical
Sir,
utility?
this is just a research topic which is going on, so we can more conclude if we'll do it on multi-centric level and with more sample size. But we can include the menstrual history and we can avoid the post-refractive surprise, sir. Post-refractive cataract surgery surprises in patients.
When do you suggest that the refractive surgery should be done in this menstrual cycle?
Pre or post, no, not during mid. Pre post करो, mid में नहीं करना.
Mid, yes.
यही है ना?
Yes,
Mid
sir.
में नहीं करना.
Yes.
ठीक.
Okay, thank you, Dr. Zainab, for the interesting case series. Ma'am, please start.
you.
Dr. Anusuya.
अच्छा उसने
Doctor.
काट दिया था. वो आ गई. Thank you.
Good afternoon, everyone. So I will be presenting a case series on multimodal imaging of Coats disease with macular nodule mimicking retinoblastoma. So in 1908, Sir George Coates first reported a case of Coats disease, which is a congenital retinopathy in young males characterized by idiopathic retinal telangiectasia, subretinal exudation, capillary non-perfusion areas, retinal detachment. Macular nodule is a well-recognized but poorly understood manifestation of Coats disease. In the Western literature, it ranges from around 23 to 53% of cases of Coats disease. However, interestingly, in Indian, the papers on Coats disease from India, none of them talk about or report any case of macular nodule in Coats. Like this particular patient, including 280 patients, none of them has been reported to have a macular nodule. So we looked into our 339 patients with Coats disease, and we found these were all treatment naive cases, and we found only 7 of them had a macular nodule, that is only 2% of them had a macular nodule at presentation. We went ahead and documented all these. So the mean age of patients of Coats disease with macular nodule was 6 years. All of them were male. It was unilateral in all of them. The median best corrected visual acuity was CFCF, and all these patients were diagnosed with retinoblastoma and referred to our ocular oncology clinic. The most common presenting complaint was decreased vision, followed by squint and white pupillary reflex. The macular nodule was located at the fovea in majority of cases, and also between the superior arcade and fovea. The color was grayish white. It was either dome-shaped or bilobed with subretinal exudation around the nodule in all the cases. There was pigmentation in a significant number of them. The second or third order retinal vessels entered the nodule and continued till apex. 1/3 of them also had calcification. The periphery showed the typical telangiectatic vessels in all of them, most commonly being in the superiotemporal quadrant, along with exudation and subretinal fluid. Optical coherence tomography showed them as a well-defined subretinal hyperreflective nodule involving the outer retina, RPE, and Brooks membrane. There was disorganization of the inner retinal layers. The ellipsoid zone and ELM were disrupted. There was posterior shadowing surrounding exudates, but no fluid. Dense localized hyperreflective areas of RP aggregates were also seen. On ultrasound scan, it was an eco-dense mass with highly reflective A scan on the surface and inside the nodule whenever the calcification was there. On fundus fluorescein angiography at the macula, early hypofluorescence with the focal leakage was seen with late staining, and at the periphery, the light bulb aneurysm along with CNP areas were noted. The primary treatment was laser photocoagulation in majority, and the patients with retinal detachment also underwent scleral buckling and SRF drainage. At mean follow-up of 8 months, the BCVA was maintained in all cases with no significant gain. So just summarizing the differences with the macular retinoblastoma, these patients have xanthochoria. It is an older age group. They're all males, unilateral, whereas retinoblastoma is in a younger age group, and the AC and vitreous might also have seeds and hemorrhage there. So the clinical appearance is different, like it is a grayish-white mass. You will see the surrounding exudation. There can be pigmentation vis-a-vis retinoblastoma, which is a fluffy white mass with feeder vessels and calcification. The periphery gives away the diagnosis with those telangiectatic vessels and exudation. On OCT, it is a subretinal nodule, whereas retinoblastoma involves the full thickness retina. On fundus fluorescein angiography, there will be blocked fluorescence because of the exudates and pigmentation, and periphery will show the light bulb aneurysm and CNP areas, which won't be the case in retinoblastoma. Ultrasound will show the presence of calcification chances are much more in retinoblastoma. Thus, to conclude, this is the first Indian study on Coats disease with macular nodule. It represents a vascular process and has an extremely low incidence in Indians. This is the first study to describe layer by layer the OCT changes in such patients. The poor visual prognosis in these cases is basically because of the extensive degenerative changes at the macula. It is of utmost importance to be aware of the typical fundus appearance and adjunctive imaging features of this entity to differentiate it from retinoblastoma and treat appropriately. Thank you for patient listening.
Thank you for a very nice study and very well documented. I think what we have been seeing is later presentation of a macular sort of a raised lesion, which is not typically what you probably by that time it has scarred, and not really what you picked up in the beginning. I think that is not uncommon. If we put those cases together, I think they may be all similar to what your cases are, but very well documented study.
Completely agree, sir. So during the course of the disease, many of them will develop, but what we have captured here are all treatment-naive cases at presentation.
That's what I'm telling, that it's not that uncommon, because we find many of these with poor vision is because of this macular large mound, which we see later, which is like a scar, not like what you presented. So maybe it is not that uncommon. Maybe we started looking at them more carefully now, and earlier how the eyes were enucleated, maybe we were not even looking at them that seriously, and probably the imaging modality was not available. Once the OCT was not there, many of them were, like for old-timer like us, many were enucleated, and this was the commonest cause of enucleation, which was mistaken, because that time the enucleation was very commonly done for retinoblastoma.
Yeah, completely agree, sir.
I think it's a reasonably good contribution. Only thing is that you in Coats disease you do not see an isolated macular nodule. You see always surrounded by exudation. Whereas in retinoblastoma, it may or may not be exudation may not be isolated nodule may be there, but surrounding exudation may not be there. Plus, no diagnosis without the periphery examination which clinches. Plus, very important is that OCT. Even if you are not very well versed with the indirect and don't see, then OCT can definitely help you out.
Yes, sir.
It was excellent documentation.
Yeah.
Whatever I think fundus finding and documentation, it was just excellent.
Thank you.
Thank you, Dr. Anusura, for the excellent presentation. I think we have concluded with this session, and the results will be announced shortly. Tomorrow, at the valedictory session. Day after, on Sunday, at the valedictory session.